We are live.
Good evening, everyone. Welcome to iFocus Online Lecture 299 and Ocular Oncology Session 6. And today we have with us Professor Apjit Kaur, ma'am, and she'll be talking on clinical evaluation of orbital tumors. Apjit ma'am is the professor and head and Department of Ophthalmology from KGMU, Lucknow. She's also the in charge of Oculoplastic and Orbit Service, and we have seen her excellent work. She has been the additional in charge as Dean of Nursing as well, and the Vice President of Oculoplastic Society of South Asia. She's the former Joint Secretary and President of OPI, and she has represented OPI at BOPSS Glasgow and has delivered several lectures at SNEC Singapore as well. She is the author of Clinical Radiological Atlas of Orbital Disorders and has written several chapters in oculoplasty in multiple books. She has received innumerable awards, including the prestigious B.K. Nara and Rao Award, Honorary FICO, for contribution of oculoplasty by AIOS, and Madhusudan Jhambar Award by Aquine. And she is also qualified she's also qualified the Health and Hospital Management Exam Gold Medalist in the same, conducted by IGNO 2016. So she is an excellent teacher and an excellent orator and an excellent clinician as well. Over to you, ma'am.
Thank you, Rolika, for all those nice words. I'll share my screen. Is it visible to all?
Yes, ma'am.
Yes, ma'am.
Okay, at the outset, the diagrams and textual photos have been borrowed, some of them from the internet, and the photographs of the patients have been used only after prior consent. So all of us know that the orbit is made of 7 bones: frontal, sphenoid, zygomatic, maxilla, lacrimal, ethmoid, and palatine. The orbit is pyramidal in its shape. The walls are curvilinear. The height of the orbital margin is 40 millimeters and the width is 35 at its margin. The depth is 40 to 50 millimeters and the interorbital distance is 25 meters. Interestingly, this interorbital distance does not change from anterior to posterior. The volume of the orbit is 30 centimeters square and a child's orbit is rounder than the adults. Now, this is a typical textbook photograph which shows you all the fissures and foramina. See, the anatomy of the orbit is very well explained in textbooks, so I am not spending much time in going into the factual details. I will be focusing more on the applied, then how we interpret, and then how we approach a patient. So this is an image which is showing you the optic canal here, the supraorbital notch, the superior orbital fissure. You see how this superior orbital fissure virtually looks continuous with the inferior orbital fissure. Here is the lacrimal fossa. So this is at the infero-medial corner, the Whitnall's tubercle where the Whitnall's ligament attaches, and here just under the rim, somewhere in the middle, is the infraorbital foramen. Now, one by one, we'll address them. The superior orbital fissure has a huge number of structures passing through it. 3 cranial nerves, these branches of the cranial nerves, the fronto-orbital branch of the middle meningeal artery, the recurrent branch of the lacrimal artery, superior ophthalmic vein. So all nerves, arteries, vein. Why is it so important? Because any fracture, edema, or hematoma, which acts like a space-occupying lesion, is capable of affecting any or all of these. And when all of these are affected, what results is called the superior orbital fissure syndrome. Now let's come to this inferior orbital fissure. Again, there is a huge list which includes nerves, the parasympathetics, the artery, the vein, and the inferior ophthalmic vein branch to the pterygoid plexus. Means that here is a place through which the orbit connects with the pterygoid plexus. 1 centimeter posterior to the inferior lateral orbital rim, this area passes and comes out here. What I showed you in the previous slide as the infraorbital foramen. So this fissure opens out here, this dot, as the foramen. And here, when the nerve gets injured, what results is facial anesthesia. So in any patient who, after trauma or with a tumor, has facial anesthesia, you know that the contents of the infraorbital fissure have been involved. Now come to the optic canal. This optic canal majorly transmits the optic nerve with the ophthalmic artery and the central retinal vein. Now, why is this important? Because the fractures extending to the canal can result in blindness. Also, all the lesions of the optic nerve which go into the canal are capable of affecting the contralateral field. Why? Because we have, what do we have here? The Mayer's loop. So what are the characteristics of these bones? These are papery thin, which makes them prone to infections. They have very thick margins, which give a protective function. The curvature is important because, you have these muscles, orbital muscles, and the eyeball is round. The the pyramid is tapering. So to fit in all that area in this tapering cone where the eyeball is there, this curvature is important. They are flat bones, so they partake in hemopoiesis. Now the medial wall is the thinnest wall, but it doesn't fracture most often. Why? Because it's very thin all along, and it is supported by horizontal sections, so which act as a scaffold. On the other hand, the floor is most vulnerable to fracture. Why? Because it is thin and unsupported. You have the maxilla under it. So there's a huge air pocket. Access to the orbital contents can be done even without osteotomy. The periorbita and the orbital septum is what is the next we are going to deal with. Can you see this thick black line traveling here? What happens here? This periorbita becomes continuous here with the periosteum of the frontal bone. Here, this periorbita becomes continuous with the maxilla. And here, this periorbita becomes continuous with the orbital septum. So virtually, this holds the insides of the orbit. Now, this periorbita shares its nerve supply with the base of skull. Where is the base of skull? Here is the base of skull. So the V1 division of the fifth nerve is responsible for this periosteal or periorbital nerve supply. And that is why whenever you have sinusitis, you have pain in the eyes. Whenever you have any sinusitis, you have a headache. So this is all because of the shared nerve supply. So 4 ligaments are important. The Whitnall's ligament, which runs from the trochlea to the lateral orbital wall here in the superior part, right? Then is the suspensory ligament of Lockwood, which is the thickened lower part of the Tenon's capsule, this. And then there's the medial and lateral check ligaments, which attach to the posterior lacrimal crest to the Whitnall's tubercle here. All this, the septum and the periorbita, they hold this yellow part, which is the orbital fat, which has extraconal and intraconal disbursements. And this acts as a cushion. So it facilitates external ocular movement. It cushions and absorbs impact and maintains the, sorry for the spelling, maintains the position of the eyeball. Now, when in disease, this part gets enhanced, thickened, this fat starts bulging. And this is the latest concept in thyroid-associated ophthalmopathy, where it has been treated as the first wall of approach. It also has a role to play in the blepharoplasty procedures, where you realign the structure of the eyelid in cases where there is fat prolapse and lengthening of the skin of the eyelids. Now, orbital arteries are important because this is the area, the orbit is the area where there is an anastomosis of the external and internal carotid systems, right? Similarly, the venous drainage is extremely important because here from the anterior superficial outer venous plexus through the orbit, you go into the intracranial part, which is the cavernous sinus. You see how everything is coming here. So the facial vein through the anastomosis with the superior ophthalmic vein into the orbit goes into the cavernous sinus. The pterygoid plexus here goes through the inferior orbital fissure, again to connect with the orbital veins and go into the cavernous sinus. What is important is to remember that these veins are valveless. So what is the importance? That any ascending infection is purely going to ascend. Lymphatics are few, but they are there. And you see they are aligned along the lateral part of the face. The eyelids drain here, majorly here. What is this? Anybody? This is what happens to a resident when you get a case of proptosis. Kuch samajh nahi aata kya karna. But it's not like that. It's very simple. There are a few things which we have to remember. The first point to remember is that all orbital tissues can produce neoplasms and can be affected by inflammations. So what are the different orbital tissues we have? We have muscle, we have fat, we have nerves, we have arteries, right? And we have bones. So everything can give rise to tumor and everything can give rise to inflammation. All conditions cannot be clinically diagnosed. The presentations depend upon the site of involvement and the etiology of the involvement. Radiology is a major diagnostic tool and histopathology confirms the diagnosis. So what is pseudoproptosis? Pseudo means false or a simulation. Simulation of abnormal prominence or a true asymmetry is not the result of increased orbital contacts. And what are the causes? Enlarged globe, contralateral enophthalmos, asymmetric orbital size, and asymmetric palpebral fissures. Now look at this. If you don't see this radiology, this child has come with a bulge. The first instinct is to say that, oh, proptosis has got. But it's not that. The eyeball is in its normal position. Look at this eyeball and look at this eyeball. They're both at the same position. This is a huge tumor, a vascular tumor in the lid. Now, whenever you have true proptosis, it is extremely important to see the closure of the eye. Because this tumor has been taken out. You see this, I've successfully treated this lady, but she has no vision. Why? Because of this big corneal opacity. So what are the criteria for proptosis? The anterior displacement of globe of one or both globes within the bony orbit. Protrusion has to be more than 21 millimeters or there has to be a difference of 2 millimeters on Hertz. On CT scan, the globe protrusion of more than 21 millimeters anterior to the interzygomatic line on the axial scans at the level of the lens. And both the levels should be the same. If the section is tilted, one is going to appear larger, the other is going to appear smaller. Proptosis without displacement is called axial proptosis, and proptosis with displacement is called non-axial proptosis. So what is displacement? When it is pushed straight in front, it is axial. There is no displacement from its primary line. When it is shifted forwards and shifted either to the sides or downwards or upwards, that is displacement. And that is a non-axial proptosis or abaxial proptosis. Now, these are some demographic values, but what is important to remember is the asymmetry, which is important. See, values can be anything. If they're the same value on both the sides, it doesn't matter. If there is asymmetry, it is crucial. Now we move on to another segment which we have to understand, which is the spaces of the orbit. Now, if you see this diagram, this is borrowed from a book. So here is the bone, here is the periorbita, then we have the muscle, then we have this white area, right? So between the bone and the periosteum is the subperiosteal space. Between the periosteum and the muscle is the extraconal space. Extraconal space. Bone and periosteum, subperiosteal space. Periosteum and cone is extraconal space. Between this fibromuscular scaffold and the optic nerve is the intraconal space. This is the intraconal space between the optic nerve and the muscle, right? And inner to this, between the globe and the tenon, is the subtenon space. Why are these spaces important? They're important because each of these has specific contents, and due to their limited nature, they have a specific presentation. So let's deal one by one. This is an axial displacement. What did we learn earlier? That axial displacement will occur when this eyeball is pushed straight in front. Straight in front will be pushed by something which is just behind it. That means the lesion has to be here in the intraconal space. So an intraconal mass in this cone, in this black area here, this will just push the eyeball in front, right? So what are the common lesions here? What are the structures here? There is the nerve. So we have tumors related to the nerve, the glioma and the meningioma. And we can have the vascular tumors, which are the cavernous hemangioma most commonly. You can also have lymphangiomas. Enlarged extraocular muscles. Look at this child. Eyes, both eyes are bulging. Here you see so much of fat is bulging. And look at the size of his muscles. This is what is called a typical Coca-Cola bottle sign. Now, this is yet another person who has such thick enlarged muscles, but his proptosis is not. Why? Why do you think it is like that? Because
asymmetrical enlargement of the muscle
is more involved than the lateral rectus muscle. So what did you learn? That these presentations are reflections of what is happening, right? Now look at this lady, huge axial proptosis. This medial rectus muscle and the lateral rectus muscle have held this huge tumor, axial proptosis. Now let's see some non-axial proptosis. What is happening here? There is fullness in the superior part. This eye is pushed downwards. And here on scan is this huge lesion in the upper part. So inferior displacement will occur whenever a lesion is in the upper part. If it is directly upper, it will get pushed directly down. If it is in the superior medial part, it will get pushed down and out. And if it is in the superior lateral part, it will get pushed down and in. Lesion is down and out, up and out. Eye is pushed down and in. Here it only tells us the position. This tumor could be anything. That we will have to assess depending upon the history. Whether it is inflammatory, it is post-traumatic, or is it a tumor? Is it a benign tumor? Is it a malignant tumor? Now let's look at this fellow. Look at the position of the eye. Laterally displaced and proptosed. See, for proptosis, it has to go behind the equator. If it is only anterior to the equator, it will only get pushed directly. This is something which you have to have a concept of. So anything from the medial side, and what is there in the medial side? There are the ethmoid sinuses, there is the medial peripheral space and medial subperiosteal space. Look at this eyeball, where it has been pushed up. So what can push up? Either something from the maxillary sinus breaks the floor, comes inside, or per se there is an inferior orbital mass, right? Now this is very important. Why is it important? Because these are space-occupying lesions, but they cause enophthalmos. The orbital venous varix and the metastatic serous carcinoma of the breast. This young man presented with a downward displaced eye, a deep superior sulcus. And he said, when I sit down to write in my class, this is what happens. This is the classic orbital venous varix where the Valsalva test is positive. Now, this part is very important. The P's of proptosis. Earlier, up till now, what had we learned? The concepts. How does it move? Why does it move? Where is the lesion? What is the displacement? Those sort of things. Now we are coming to a second segment, which is evaluation of proptosis per se. To learn this very nicely, all these three intelligent people, they coined these 6 P's of proptosis. The first 2 P's are the pain and progression, and the next 4 P's are from the examination. First 2 are from history, and next 4 are from examination. So if there is a history of pain, what do you think can be the reason? Inflammation for sure. Inflammation may be autoimmune or infective, right? Infection could be bacterial. It could be fungal. It could be viral. What else will give rise to pain? Pressure.
Increasing orbital pressure.
Where there is expansion, acute pressure, sudden hematoma, eyeball is pushed forward with a lot of expansion of tissues, a lot of pressure on the tissues inside. Bony involvement, nerve involvement, periosteal involvement, all these give rise to pain. So you can have pain in an abscess, pain in cellulitis. You can also have pain in a lacrimal adenoid cystic carcinoma, where there is perineural infiltration. Progression, again, you have to see the type of progression, whether it is rapid, occurring in hours or days, intermediate progression, which occurs in weeks to months, or a slow progression. Rapid progression is usually vascular in nature or post-operative. which occurs with benign inflammations and not infective inflammations, with the autoimmune type of inflammations and with benign tumors. And slow progression, again, is associated with tumors. Now, here was a child. He went out to play and came back with this bulging eye, rapid onset of proptosis. Within a matter of half an hour, 45 minutes, bacha ghar se theek gaya. When he comes back crying, this is the state. What do you think it can be? A bleed. Now, this bleed or hematoma could be because of trauma, or it could be spontaneous in a lymphangioma. Right? So we aspirated this and obviously clenched our diagnosis. So to evaluate a patient of proptosis, what do you need? You need a torch. You need 2 transparent 6-inch scales. You need a Hertel's exophthalmometer. You need cotton, fluorescein, some perfume, and a little ammonia. Coming to this examination, then again, we see whether it is axial or abaxial and how much is it. This how much will be dealt by these different methods. You can choose any one of them, either the Hertel's or the 2-scale method or the 1-scale method or the Lude's method. Now come to examination. Now, you remember your examination from surgery, palpation, right? There were 2 types of palpation. One is a soft palpation and the other is a deep palpation. So the soft palpation is a gentle touch of the rim and the periocular tissues. It will tell you whether there is any pain, whether there is difficulty, there's a breach in the continuity, or there is an elevation, is there a bony thickening. Then what you will do, what is called the orbital tonometry. Ask the patient to close the eyes, rest your thumbs on the eyelids and push backwards. What does that tell you? If it can be pushed, if there is no or little resistance, you know that whatever there is behind is giving way. What will give way? Something which is soft. What is soft? Tumors. Right? So if there is compressibility, it is either vascular or lymphatic. And when you push back, if it is firm, then there is something which is stiff. It is either a neural tumor or it is dilated muscles, as in thyroid ophthalmopathy, or there is some other tumor which is solid, right? So compressibility indicates vascularity, all others are firm. If it is very hard, you know it is bony in nature, or tense cystic, like the deep dermoid cysts, the posterior dermoid cysts. So whenever you talk of a mass in the orbit, the parameters of evaluation are the same, like you did in your general surgery. Where is it? How big is it? What is the surface like? What is the consistency like? Is it fixed to the underlying structure? Is the skin over it fixed? Is it tender? What is the temperature like? Is it transilluminate? All these points will be applicable to this orbital mass also. So this is just a picture of what I was saying, orbital tonometry. This is transillumination. Now see, it's hanging like this. But the moment you put a pen torch, don't start doing transillumination with that big jeep wala torch, jo foresters leke chalte hain, wo nahi. You need a small pen torch, right, with a focus light. So when you put this focus light on it, see how brilliantly transilluminant it is. What does it tell you? It has blood or fluid?
Fluid, which is clear.
Fluid, which is clear. Palpation, again, pulsations. This is another important part. The true pulsations and the transmitted pulsations. What are true pulsations?
They're expansile in nature. They move the finger.
Come from a true arterial component. They correspond with the heartbeat and come from an arteriovenous communication. Whereas the transmitted pulsations come from something else which is pulsating outside of this lesion, like the brain. So if you have a meningoencephalocele, it is not the meningoencephalocele that is pulsating. What is pulsating? The brain. The brain is pulsating. And here is a defect through which this pulsation is being transmitted. This lady again came with enophthalmos. She looked down and see how all this has become full. Now you examine for the other P, which is the periocular change. So what are the different periocular changes? There is pigmentation, which occurs in melanotic lesions and in neurofibromatosis. There is temporal flare, which occurs in thyroid-associated ophthalmopathy. There are eyelid positional changes, which occur in tau. Dilated veins, which is a sign of subsinus thrombosis. Telangiectatic vessels present on the surface is a sign of intralesional vascularity. A salmon patch on the eyeball is indicative of lymphoma, and temporal fullness is a sign of a sphenoid wing meningioma. Huge lesion here on the right upper lid causing mechanical ptosis. And this lid is darker and larger. This is a large cafe au lait spot. And this typical S-shaped deformity, both these conditions are associated with
Neurofibromatosis.
Now, this was a very interesting lady. You see, she has diffuse congestion of the conjunctiva. She has this huge knuckle here on the left upper eyelid in the medial part. And she has been going from pillar to post, being treated as scleritis, episcleritis, and the works. Narrow angle glaucoma, masquerader. And when I discovered this thick connection here, we got a venogram done for her. And can you see this backflow here? This was a left upper lid superior venous thrombosis. A child who has proptosis. She had fever, developed this proptosis and this bluish hue here. What is the diagnosis?
Maybe a veno-lymphatic malformation.
Yes. Why not an orbital cellulitis? She had associated eye fever. Why does one not think of orbital cellulitis here?
The discoloration and the fullness of the upper lid.
The conjunctiva is not injected. Orbital cellulitis, you will get a injected conjunctiva also along with the proptosis and inflammation on the lid. Here the lid is not inflamed. Only the eyeball is proptosed and the lid is bluish in color. Typical salmon patch, suggestive of lymphoma. You see this fullness here? This boy had a sphenoid wing meningioma, the lateral part of the sphenoid wing. Then you examine the neighbors. Who are the neighbors? The cranium. What do you see in the cranium? The size, the sutures, any irregularities. You test cranial nerves from 1 to 7. Paranasal sinuses, you see the nasal cavity, you see the cutaneous sensations, you see the contour. You check the oral cavity, the palate and the mouth opening, and you check the ear. All these are capable of giving rise to lesions in the orbit. So let's go through some cranial signs. You see this forehead? Fullness of the forehead. This eye is pushed downwards. There is a fullness in the superior part. The glabella is full. Radiology shows you a huge fibrous dysplasia. Can you see this? Everything is white here. Let's look at this child. Bilateral swellings. He has a lesion here on the skull. Bilateral lesions here. Lytic lesion of the bone here. What is this? Primary neuroectodermal tumor. PNET. Look at this lady. Huge lesion here. The frontal sinus is full. This is a frontal sinus malignancy. Another person who presented with proptosis of the left eye with lateral displacement. You see his ethmoid is full. And there is destruction of bone. This is a fungal granuloma of the ethmoid sinus. Here another person. Can you see this? Huge cheek, proptosis here. This was a rhabdomyosarcoma. A patient who presented with orbital cellulitis, responded to antibiotics, has this trismus. So always check for these oral signs. This boy with orbital cellulitis, you see this chemosis of conjunctiva, proptosis, fiery looking, subperiosteal abscess here. Site of focus of infection is pinna. Can you see this? He has external otitis and he has this cartilage involvement. So on examination, systemic examination, you need to see these skin lesions, skeletal deformities, to secondary tumors. So now let's give some time to revision of what we have learned. All this was basic theory. Let's put it to some use. What do we do when we get a patient? That's why we are scared of proptosis. Na? Kya karna hai? Kya sochna hai? So the first thing you have to do is the age of onset, history. Kab shuru hua? When did it all start? So if the child was born with it, it is something which is congenital. If it was acquired, you have to find out whether it was acquired in the pediatric age or as an adult. Was the onset acute, subacute, or chronic? Very often, it is present congenitally. The patient does not notice it. So you have to ask who noticed it. But you will come across such situations when these children go for recruitment, for army, police. Suddenly they are told, "Tumhari ek aankh badi hai, dusri aankh choti hai." And then they start running. What happened? What's the disease? CT scan hua, kuch nahi nikla ye. Where should you go back to? Who noticed it? And if it wasn't noticed by the patient, get old photographs. Is it a congenital, just a physiological variation? Do the refraction. See if there is high myopia in one eye. Right? Then you come to the course, whether it is progressive or non-progressive. If it is progressive, whatever the pathology is active. And what are the active pathologies? Trauma is not active.
Infection.
Heat is not active. Infection is active. Inflammation is active. Tumors are active. Thyroid is active. Right? So the course is very important. If it is progressive, whether it is sudden or rapid, and if it is non-progressive or regressive. Hematoma hua, resolve kar raha hai. It will become regressive, right? Now, what are the associations? Trauma, surgery, systemic disease, what is it? Now, the history, just give me a minute. So the associations are trauma, surgery, or any systemic disease. Then you need to find out the history related to the orbital disease per se. Whether there was pain with or without fever. What is the visual involvement? What are the other ocular symptoms? Does he have diplopia? Was there watering? Is there proper eye closure? All this has to be asked for from the patient. Then you come to history, which is related to the sinuses, cranium, or the systemic diseases. And then a very important segment of history is what is the response to the earlier treatment. Now, when you come to examine this patient, you ask for vision. Is there visual involvement? If there is visual involvement, what could be the reasons for that visual involvement? Is it the nerve per se? Is it because of the displacement? Is the position of the lesion causing visual confusion? Or is it the inadequate closure which is causing exposure keratopathy, which is causing decrease in vision? So the condition of the visual acuity is extremely important. Then you inspect the patient just as you look at the patient when he comes towards you. Facial symmetry. Under what headings will you look for the facial symmetry? The position of the eyebrows, the bilateral palpebral apertures, the malar prominence, the nasolabial folds, and the angle of the mouth. 5 points, you quickly scan the face. It will give you an indication where the lesion is. If there is more of the malar prominence on one side, you know that there is a maxillary lesion sitting there. If you see that this is flat and the eye is pushed outside, you know that probably there is a upward displacement of the fractured segment, which is possibly pushing it out. Then you see whether the lesion is bilateral or unilateral, whether there is eyelid closure. Now you look at the condition of the conjunctiva and the cornea. Why is this important? Stasis of the venous system reflects as conjunctival congestion. What conditions would you see it in? Thyroid ophthalmopathy, orbital thrombosis, right? Then you look at the type of proptosis, whether it is axial, abaxial, pulsatile, non-pulsatile, all that you have to see. And then you look for any obvious associated signs. Once you have finished with this inspection, then you come to the palpation part. Divide your palpation into two. The soft touch, and the deep touch. What do you do with the soft touch? You look for signs of inflammation. Garam hai, nahi hai. Is the temperature the same? Is there what typical in signs of inflammation are? Rubor, dolor, right? Is it there? Can you feel any pulsations? Are there any surface characteristics? Is it an irregular mass? Does it have a bag of worms feeling? All those signs that we learn along with the disease, that has to be verified here. And then you do the deep touch. What is the deep touch? When you have localized that there is a mass, then you see whether you can palpate the posterior extent or not. Or is it only the anterior extent that you know? Is it fixed to the bone? Is it fixed to the underlying structures? How is it related to the movement? What is the tonometry like? Is it compressible? So all that we had learned has to be put into practice under this heading now, right? Then you see the ocular motility, whether it is being pulled or it's being pushed. Is there diplopia? Is there no diplopia? You do a slit lamp examination, especially for the iris and pupil. Why iris and pupil are important? See, the pupil is important because it will help you differentiate between an axial proptosis, which is because of a glioma or because of a meningioma. A glioma is primary neural tumor, right? So there is visual loss, and this visual loss is associated with absence of direct response. Whereas a meningioma is from the meninges. It may or may not cause neural compression. So if vision is retained, axial proptosis is there, the pupillary reaction is present, and the tonometry is hard, it's likely to be a meningioma. If the vision is retained, the pupil is responding, but the tonometry is soft, it is like to be a vascular or a lymphatic mass, right? Then you come to the fundus evaluation. Why is fundus evaluation important?
Pressure signs of
Any pressure on the globe can lead to choroidal folds.
The thing which you should always remember is that if it is an intrinsic tumor of the optic nerve, like the optic nerve glioma, you will always get a primary type of optic atrophy. Whereas if the meningioma is posterior, in the posterior part of the optic nerve, or in the anterior part of the optic nerve, the fundus signs will be different. Where does the optic nerve and the venous system enter into the optic nerve? 1 centimeter anterior to the optic foramen, right? So if the tumor is arising from the posterior part, you will get a primary type of atrophy. But if it's in the anterior part, where the vasculature is inside the nerve, it will get choked. And then you will get a stasis type of picture. Also, if there is a superior orbital fissure involvement, where the venous system is choked over there, there will be a retrograde fullness of the retinal veins. That is why fundus evaluation is so important. Then you do your cranial nerve evaluation. First, cranial nerve, you know, how do you test it? Through smell. Second, cranial nerve, through the pupil and fundus examination. Third, cranial nerve, through, how is the third?
Ocular motility.
The ocular motility. The third, fourth, and sixth. How is the fifth tested?
Sensations of the frontal supraorbital.
In 3 parts, in the forehead, on the eyeball, and in the region of the maxilla, right? And how is the 7th nerve tested? By eye closure. Then you have to do the quantitative measurements of the proptosis. So is all this clear? Is the anatomy, the correlations, the points of evaluation, and the approach to a case clear? Have I been able to come across or no?
Yes, ma'am.
Yes, ma'am.
Then you see for what investigations you have to do. The investigations are broadly divided into 2 parts. One is the general for the fitness for surgery, right? Where cardiological evaluation, hematological evaluation. And then you have the second set of investigations which are specific for the diagnosis. Here again, you have your radiological evaluations, which is the USG, the CT, and the MR. There is the histopathology, which could be either a fine needle or the final histopathology or a incisional biopsy. And you have the vast gamut of hematological investigations these days with the autoimmune workup, especially for the IG4 disease and others, and the endocrine workup for the thyroid ophthalmopathy. Any questions?
Thank you so much, ma'am, for that very, very comprehensive talk. As you said, that actually when you get a case of proptosis as a postgraduate, it is little unnerving. But I hope from your talk, like PGs will gain confidence and know how to systematically actually go about it so that it becomes easy. It's actually all about the examination and differentials rather than.
Remember two basic points. The dynamism of push and pull,
Correct.
and the presentation of the different sections of etiology. What are the different? Congenital, inflammatory, neoplastic, autoimmune, endocrine, and trauma.
Correct.
So broad presentations of these matched with the dynamics of push and pull. That is all that proptosis has to it.
Yeah. And actually in any other case, it's all about the systematic examination rather than cracking the diagnosis, I think, in the exam. So I think if they go systematically, I think the points are all for that, rather than like telling whether this is like a case of meningioma or like a...
There are very few conditions in the orbit where you can for sure say that this is the diagnosis.
Correct, ma'am. Yeah.
It's called the Pandora's box.
Correct. Yeah, we have few questions from the social media portals, ma'am. One is, what are the important anatomical landmarks to be kept in mind during a DCR surgery?
So for a DCR, the most important anatomical landmark is the anterior lacrimal crest. That is the most important. If you palpate your anterior lacrimal crest and place your incision right on top of that, you will never go wrong, because everything else falls in place.
Yeah. And I think the next one is also related to the same, I think DCR surgery, because people do it so frequently. What is Suchara Natha and its clinical significance?
I actually have not included any part of the SAC in this evaluation of proptosis. So I would rather keep it for some second session, because to show all that I need a diagram and,
Correct, ma'am. Anatomy, relevant anatomy. Yeah, correct, ma'am. Next one is ideal technique to use exophthalmometer, Hertel's and Lewis's exophthalmometer.
See, if you look at the can I go back to my presentation? Okay, if you remember the exophthalmometer, the Hertel's, so there is a central part which you mark as the K reading. That K reading is the reference point for that patient. How do you come to that K reading? By placing the edge of that notch on the lateral orbital wall at the level of the lateral canthus, parallel to the canthus. Then you mark your K, and this K is specific to every patient. So once you have marked that K, and then you look at the reflection of the cornea in the prismatic mirror of the Hertel's. Noting the K is very important. Because if you don't note the K and you shift your K readings next time, K reading will depend upon where you have put the lateral bars, the edges. If you remember the Hertel's, there are two notches, one on the right and one on the left. So once you place, that notch has to be properly placed. Anything else? And for the Ludes, of course, it's very simple. You stand on the side of the patient and it has to be horizontally placed. What is important is it has to be horizontally placed. And then you, of course, see the reflection of the cornea where it's cutting that scale.
Yes. Next one is, ma'am, what all things to be examined in a case of orbital fracture?
Okay. See, for orbital fracture, the first thing that has to be seen is the level of the eyelids. Are both the eyelids at the same level or not? How much is the enophthalmos? Whether the corneal sensations are involved or not. And whether the facial sensations here, because of the infraorbital nerve, are they involved or not? These 4 points are very important. Along with this, you have to see the movement of the eyeball, whether it is suggestive of a paralysis or is it suggestive of an entrapment. How do you differentiate whether it is suggestive of an entrapment, or how do you differentiate whether it is suggestive of a paralysis? See, ptosis can be present. A floor fracture, a blowout fracture can have ptosis. It can have enophthalmos. It can have restriction of elevation, right? But it will not have restriction of adduction, right? That is how you will differentiate it from a paralytic third nerve. Which will also have ptosis, where again the child or the patient may not be able to elevate because of inferior rectus involvement. But then there the third nerve, medial rectus, will also be involved.
Yes, ma'am. And ma'am, the next one is the importance of inferomedial strut in orbit fracture.
Very important. Very, very important. Why? Because that actually decides where and how you are going to place your graft or whatever you are planning, if it is an autologous or whatever, medpore or whatever implant you are using. In that case, it is the strut which becomes your guide. So that strut is very important.
And ma'am, that is true for either a titanium plate or a medpore that we use anatomically.
Until and unless you are not going into the orbit and plating it and just plating it from outside. If it's an anterior plate only, if you are putting a mesh only in the anterior part, then the strut doesn't matter. But if you're going inside, if you have a superior component to it, then the strut is very important.
Next one is, ma'am, what are the important applied anatomical aspects in a case of orbital cellulitis?
Applied anatomical. What does the question, first of all, mean? I'm not very clear, but as if I understand correctly, basically they are wanting to know how does it affect the vision? How does it affect the external ocular movements? Basically, you need to understand that an orbital cellulitis, the infection has gone behind the septum. It has become post-septal. If it is pre-septal, it is not orbital cellulitis. That is one concept that has to be cleared. The second thing is that when you go behind the septum, it is all a very closed compartment. So here, everything is prone to compression. So if the expansion is so much that the fat is not able to sort of offset it and the pressure is transmitted to the nerve, optic nerve, then you tend to lose vision in orbital cellulitis. And that is where you need to do that release of the lateral canthus. And how do you know whether you are impending that situation or not? Your pupillary reaction is your guide. So in every case of orbital cellulitis, a very, very crucial examination, because if it's a child, the pain is so much that they will not cooperate for a visual acuity on Snellens and all. They'll not even open their eye. The inflammation is so much. You need to do is that with the normal eye, ask the patient to look into the distance. Because if you ask the patient to look, acha beta torch dekh lo, and the torch is right here, then what is going to happen? It is a near reflex system. Yes, that will get elicited. So to avoid that, check the pupillary reaction from the other side. Right? ask them to look into the distance and then see this pupillary reaction. So it's important that the most important applied, I would say, is related to vision. The second important applied aspect is your spread of infection. That is it still limited to the orbit or is it going posteriorly? How do you do that? In the mastoid tenderness. So in every patient of orbital cellulitis, you must check the vision, keep a track of the pupil, and check for the mastoid tenderness. Closure of the eyelid, of course, that is very important to avoid exposure keratopathy because of the proptosis.
Great, ma'am. Thank you so much, ma'am, for covering our questions as well. And thank you so much for sparing your time this evening with us to be a part of our program. You made it so simple, actually, and so many important pearls that I think every student and postgraduate and even like fellows and practicing ophthalmologists, they will take away many, many important pointers from your class today. Thank you so much, ma'am. I hope you also enjoyed being a part of our program today. So next we will meet on 26th April and the topic is orbital tumors. We'll continue with the orbital tumors, the clinical spectrum, and that is by Dr. Santosh Navasa. So we'll see you all on 26th April. Have a good night, everyone.
Same time?
Same time, ma'am. Yes, ma'am, 8 to 9. And we'll be honored if you are a part of the